disorder in children.
Assalamu alaikum. First of all, I'd like to thank Dr. Khalid and Alexandria University for inviting me to this first pediatric neuroradiology conference. I will talk about the value of CSF flow studies in the management of CSF disorders in children. My objectives are to review the anatomy of the ventricular system, recognize MR protocol for evaluation of CSF disorders, understand the value of different sequences in the assessment of common clinical presentations. As we all know, there are two lateral ventricles and third ventricle passing into aqueduct into the fourth ventricle, and these are the choroid plexus which produce CSF, which is then reabsorbed through arachnoid granulations into the cerebral sinuses. MR protocol starts simply with axial T2 weighted image. We can see here nicely the third ventricle as slit-like structure, and these are the two lateral ventricles and the normal white matter surrounding. FLAIR can demonstrate the abnormal white matter more accurately than T2 weighted image, as we all know. Coronal T2 weighted image is important for demonstration of the ratios between the body of lateral ventricle and the temporal horn of lateral ventricle, also the anatomical location of the hippocampus, which can guide us to differentiate the hydrocephalus from ventricular dilatation ex vacuo. Also, a sagittal T2 weighted image, this is a sagittal T2 weighted image. However, the more sensitive and the most important sequence is the high resolution, three-dimensional, heavily T2 weighted sequence. We can see here nicely the anatomy of the third ventricle. These are the suprasellar cistern and the chiasmatic cistern. Also here the posterior binary recesses, anterior and posterior recesses of the third ventricle. We can see here the floor of the third ventricle convex upward, and this is the lamina terminalis. And this is the iliac west membrane, a thin slit-like structure beneath the floor of the third ventricle. 3D acquisition show bright fluid signal intensity with high spatial resolution, so we can enable us to accurately evaluate the subarachnoid space with demonstration of any adhesions passing through the subarachnoid space. These are different sequences. This is a modified, fully focused steady-state sequence, and these are the two T2 weighted sequences by fast spin echo technique. In Ain Shams University, we use balanced fast field echo by Philips machine and drive sequence in assessment of CSF. So what are the differences between the two-dimensional sequences and the other three-dimensional sequences? In two-dimensional conventional sequence, we can see the signal void appear more obvious in conventional T2. In drive sequence, it appears as a slit, less obvious than conventional T2 2D sequence. And in balanced fast field echo, we can see no signal void of the artifact, a flow artifact within the floor of third ventricle here. And so it is important for demonstration of the anatomy without any flow-related artifacts related to the CSF flow. Also, phase contrast sequence is retrieved with three types of contrast. This is a background image, refocused image, and this is a magnitude image. The CSF appear as a flowing structures, appear as bright signal with suppression of any surrounding background. And phase image, we can see the flow according to direction in bright or dark signal. During systole, the flowing CSF appears as dark signal, while in diastole it appears as bright signal. It is retrieved as in cine-mode image. We can see here alternating dark and the bright signal in systole and diastole. However, a phase contrast image, only bright signal through over the cardiac cycle. We can see the floor in the prepontine cistern and in the anterior spinal subarachnoid space, posterior spinal subarachnoid space, and pericellular CSF spaces here. Also, phase contrast can be acquired in axial sections perpendicular to the aqueduct of Sylvius with measurement of the ROI here, with drawing ROI surrounding the aqueduct. We can have a curve of CSF flow, either velocity or flux. Systolic velocity and diastolic velocity are variable according to the patient's age and also according to the machine. And these are, apart from velocity, we can measure stroke volume, net flow, peak velocity, and mean velocity. And we can see the normal range is variable according to the study population and according to the machines. So what are the values of CSF flow studies? First, it diagnoses of hydrocephalus, also determines the type of hydrocephalus, either it's communicating or not. Also demonstrate the site of obstruction in non-communicating hydrocephalus, also in pre-operative assessment, especially prior to third ventriculostomy, also following the operation, and also for VB shunt assessment. First, what is the hydrocephalus? Hydrocephalus means what? Water in the brain. It's ventriculomegaly that's associated with increased intracranial pressure. We can diagnose simply hydrocephalus when the ventricular enlargement associated with gyral effacement against the inner tail of the skull. This goes with hydrocephalus. However, if there is dilatation of the cisterns, that may be ventriculomegaly ex vacuo. However, the differentiation of hydrocephalus of ventriculomegaly in this, by this sample demonstration is usually not accurate in children. So how can we differentiate? These are three types forms of ventriculomegaly. In addition to the clinical situation, however, in many cases, the clinician can't judge is this hydrocephalus or is this ventriculomegaly ex vacuo or is this benign dilatation of the extra-axial CSF space. So how can we differentiate? This is hydrocephalus, this is ventricular dilatation ex vacuo, and this is benign external hydrocephalus. How can we differentiate? There are several diagnostic clues. The most important two is enlargement of the anterior and posterior recesses of the third ventricle with downward convexity of the floor of third ventricle. This results in decreased mammillopontine distance. The other clues are supportive, however, the first two are the most important ones. There is also dilatation of the temporal horn in proportion to the body in proportion to the temporal horn of lateral ventricle, with narrowing of the ventricular angle and widening of the ventricular horn radius, also with effacement of the cortical sulci. The first two, as we said, are the most important diagnostic clues. We can see here there is dilatation of the anterior recess of third ventricle, and this is the normal third biennial and supracellular, the supracellular recesses, chiasmatic and supracellular recesses having acute angle. However, here there is dilatation of these chiasmatic recesses. This goes with hydrocephalus. Also in coronal sections, we can see temporal horn, the body of the lateral ventricle is dilated in proportion inward compared to the ventricular dilatation ex vacuo with cerebral then it's an actual normal location in cases of ventricular dilatation ex vacuo. These measurements are proved to be not reliable alone in differentiation between hydrocephalus and ventricular dilatation ex vacuo. Also the events index. So is this hydrocephalus or atrophy? We can see here dilatation of subarachnoid space here, and the recesses of the third ventricle is maintaining its normal acute configuration. The floor of third ventricle and all the recesses. So this is ventricular dilatation ex vacuo, secondary to cerebral atrophy. However, the other two, there are different degrees of hydrocephalus. Second, CSF flow studies can determine the type of hydrocephalus, either it's communicating or not communicating. This case of conventional 2D weighted image is showing the flow artifacts through the aqueduct, meaning there is accelerated flow within the aqueduct. This goes with communicating hydrocephalus. However, we should confirm by thin sections 3D high resolution T2 weighted image. We can see normally patent aqueduct, and this sequence B balanced fast field echo, which can omit the effect of flow during imaging. So there is flow within the aqueduct and flow within the exit of the fourth ventricle in conventional 2D T2 weighted image. Is this communicating hydrocephalus or what? Going to the thin sections balanced fast field echo, we can see here there is a membranous obstruction in the exit of the fourth ventricle. So what is this signal void? This means there is partial obstruction here causing turbulence of flow leading to signal void in conventional 2D weighted image. And so from these scenarios, we can raise the importance of a balanced fast field echo. Also, in addition to the demonstration of the type of hydrocephalus, we can see actually determine the site of obstruction, as we said, the case of a foramen of Monroe obstruction here in sense sections, reformation of the 3D coronal reformation here. We can see obstruction at the foramen of Monroe. Also, we can see in the aqueduct of Sylvius here. And in the semi-phase image, we can see no flow within the aqueduct. Again, there are different types of aqueductal obstruction here. Aqueduct is obstructed here, here, and also here at the fourth ventricle. And this is the fourth ventricular exit. As we said, this is obstruction at the fourth ventricular exit with no flow here in the posterior spinal subarachnoid space and all surrounding the cerebellar hemispheres. Also, maybe this is an image of the 3D image. We can see obstruction at the fourth ventricular exit. Axial T2, there is membranous obstruction here, and again, no flow here as the exit of the first ventricle. However, there is flow as aqueduct. Here, this is the flow of aqueduct. From my work, we found that obstruction, intra-aqueductal obstruction, leads to accelerated flow and high velocity here, as we can see, more than 10 or 12 centimeters per second in intra-aqueductal obstruction. Prior to third ventriculostomy, the most important thing is to demonstrate if there is membranous adhesions in the prepontine cistern or the iliac west membrane, which is a normal anatomical variant that should we comment on in my report in patients which plan to perform third ventriculostomy. As surgeons, when he knows that there is a iliac west membrane, he knows it is there, and he should manage the case according to its presence by endoscope. Also, these pre-pontine adhesions, so the clinician can, or surgeon can judge if there is this candidate for endoscopic third ventriculostomy, or this patient is going to fail if the ventriculostomy is performed. In the post-operative assessment here, this case shows fenestration in the floor of third ventricle with signal void of flow, and this confirmed by phase contrast image. We can see here the signal here in the floor of third ventricle. This is a patent third ventriculostomy. So this case, is this case functioning or not? This is the early post-operative film. This is a conventional 2D weighted image. We can see here a signal void. So is this patent or not? I should go back to the balanced fast field echo sequence or the sense section sequence without any flow artifact. We can see here the floor here, there is a fenestra in the floor of third ventricle. However, there are many adhesions here. So this case is going to fail. And this is 3 months follow-up here, no flow even in 2D weighted image. So sense sections, a high resolution 3D image is crucial, very crucial in the assessment of cases of hydrocephalus. In cases of hydrocephalus, we can see the ventricles can be still dilated even with failure, with the success of the operation. We can see a patency of the floor of third ventricle and the flow. So why the ventricles are still dilated? It's known that ventricular size reduction is easier to identify in patients with acute hydrocephalus. However, in chronic hydrocephalus, the ventricular size can be still dilated, or even the change in size can only be perceived by accurate volumetric assessment. Again, in the post-op assessment, we can see here there is pre-pontine adhesions with no flow in phase contrast image. This means the patients failed third ventriculostomy. So these are the two cases, one with functioning ventriculostomy, and this one, no flow in the floor of third ventricle and no flow. This means failure of third ventriculostomy. The last part, ventricular shunt assessment. This coronal T2, we can see the shunt here. By phase contrast, we can see a bright signal demonstrating flow. However, I can't rely upon phase contrast image, as the flow within the ventricular peritoneal shunt can be interrupted in normally patent shunt. So I can't rely on functional assessment alone. I should again go to the high resolution 3D sequences. This case came for shunt evaluation. We can see the shunt is nicely demonstrated. It's patent here, and the reservoir with no collections around the reservoir, no signs of failure, with clearly visible lumen of the shunt. So this is a patent shunt in its cranial portion. Also, another case showing clearly demonstrated patent shunt here. Presence of white matter edema surrounding a shunt is a sign of failure. Also, presence of edema surrounding the reservoir is a sign of failure as well. This case shows marked dilatation, marked fluid collection surrounding the shunt. This is a sign of failure. So this is a conventional 2D T2 weighted image. Is this shunt functioning or not? It's patent or not? I can judge from this conventional 2D sequence. So again, I go to the high resolution sequence. We can see here the shunt showing intraluminal signal void debris here adjacent to the choroid plexus. It can have choroid plexus ingress in addition to the debris. So this shunt is obstructed as this segment. Another case, a conventional 2D sequence, we can see here the shunt. Is this shunt patent or not? I can judge from the ventricular size alone, as we said, that the ventricular size can't reduce in size following shunt placement. Is this, besides clinical suspicion of shunt malfunction, how can I judge? Again, going to the 3D high resolution sequence. We can see here the shunt surrounding by filaments here or with intraluminal debris shows this shunt is obstructed. So again, is this shunt, can you judge where is this shunt lie exactly from this 2D sequence? This is a shunt here, this is the shunt. Where is this location actually? Is this patent or not? By 3D reconstruction, coronal reformat, we can see here the shunt here is outside the ventricular lumen completely. So, sagittal 3D sequence is crucial for assessment of anatomy of CSF pathway. 2D phase contrast is in mid-sagittal sections, has complementary role regarding functional assessment, detection of flow with velocity measurements. MRI is important to determine if the hydrocephalus is communicating or not, and to take the site of obstruction. MRI is valuable in preoperative and postoperative assessment of third ventriculostomy, as well as detection of shunt malfunction. For further reading, this our publication from Ain Shams University, the poster published in ECR 2018 and received the Camlod Award, and as our other papers in shadow nervous system, also in insights into imaging. And thank you very much.